Good morning. This is Dr. Thomas Johnson, and I'm going to be talking this morning about anophthalmia and socket reconstruction. So it's a pleasure being here. Welcome to everybody. So let me go ahead and get started. Anophthalmia has always been a big interest of mine. This is a painting from the 15th century showing an anophthalmic patient who had lost his eye, and one can see the poor cosmetic result. This patient has no implant, he has no prosthesis. So we've come a long way from there, but we can always improve on our techniques and our care of these patients. This is a very important topic because patients who lose the eye have a lot of different problems. They have cosmetic issues, they have loss of self-esteem, they have discomfort, and so forth. And so whatever we can do to make this a better situation for them so they can feel like themselves, so they can feel like they look good and they feel good is so important. Some of my most grateful patients are my anophthalmic socket patients. And it goes a long way to really take care of these patients very carefully, instruct them on how to care for their anophthalmic socket and prosthesis, get adequate follow-ups, and do correct surgeries to, one, enucleate the eye if that needs to be done, and two, reconstruct the socket if that needs to be done. So some of the features of the functional anophthalmic socket I've listed here. They include the implant has to be centrally positioned and adequate volume. We need healthy mucous membrane sockets to line the fornices. We need good lower eyelid tone to support the weight of the prosthesis, and we want to have normal upper eyelid function and position so the upper eyelid can close over the prosthesis and wet the prosthesis and give a very natural appearance. So this is one of my patients. I think we achieved this success. This patient is a young man who unfortunately lost his right eye, and he has an anophthalmic socket on the right. He has good volume. He has nice eyelid tone. He can close over the prosthesis. The implant is centrally placed, and his prosthesis is well made. So when he blinks, he wets the prosthesis, and almost everybody does not even realize he has lost the eye. This is what we try to achieve. So to prevent complications of the anophthalmic socket, we have to start at the beginning with enucleation or evisceration. Very careful, meticulous eye removal. I teach a lot of our residents and fellows how to do enucleations, and it goes a long way if you do it properly the first time. Do very careful, meticulous technique. We try to get an adequate size orbital implant, a spherical implant. Usually in an adult, it's about 21 to 20 millimeters in diameter. Try to work with an ocularist to make a custom quality prosthesis, and preferably using an impression technique and heat curing of the acrylic. I always tell my patients that they are kind of married to me for life. They need to come in for routine maintenance with the ophthalmologist, myself, and with their ocularist every 6 months. We take the prosthesis out, we look behind it, we look for signs of inflammation, socket discharge, infection, and the prosthesis is polished by the ocularist. I think this is very important. So let's first start off with the enucleation. We had some questions regarding enucleation. This is done at least in my practice, most commonly done with local anesthesia with sedation. Just a retrobulbar block can suffice. Some patients do need general, especially if the patient is a younger patient, a child. Of course, we use general. We do a careful conjunctival peritomy, as you can see here, trying to spare all the conjunctiva we can, going right at the corneal limbus and making the peritomy 360 degrees. We isolate all of the rectus muscles with muscle hooks, and I pass a double arm 5-vicryl suture through the muscle insertion and lock it on both ends so we can isolate each of the 4 extraocular muscles. And then I just disinsert the superior and inferior obliques. This shows all the muscles having been isolated and tagged with 5-vicryl sutures. You can see double arm. I placed an implant in the socket, centrally placed, and then I make what I usually do is wrap some type of wrapping material around the implant. And in this case, I used iBank sclera. You can use micro mesh. You could use temporalis fascia. There's a number of materials you can use. And some implants you can sew right onto the implant. But in this case, I used a iBank sclera, and I placed it centrally in the socket. And this is just showing the type of implant I like to use. This is one of many. This is a porous polyethylene. You can also use acrylic, silicone. There's a number of different types, but I like this one because it's porous. It becomes integrated into the socket. I know that's not available everywhere, so one can use silicone or acrylic as well. And in this case, I cut windows into the sclera so I can bring the sutures from the muscles into the implant and sew them to the implant. And then I carefully close the Tenon's capsule, and then I carefully close the conjunctiva. So the anophthalmic socket syndrome is something we've all seen in patients with anophthalmic sockets. It's patients who come in with a poor fitting prosthesis, ectropion. Sometimes they have spontaneous loss of the prosthesis, so forth. Sometimes they can't wear a prosthesis at all. Some of the characteristics include volume deficiency, lower eyelid laxity with ectropion, poor movement of the prosthesis, and then downward displacement of the prosthesis due to loss of lower eyelid tone and sometimes shifting of the implant. So this is a patient with anophthalmic socket syndrome. One can see the patient has a very deep superior sulcus, loss of volume. The patient has lower lid laxity with a little bit of sagging of the lower lid. If you look at the level, the prosthesis is displaced downward. Another patient here with a classic anophthalmic socket syndrome. This patient has loss of superior volume, lowering of the prosthesis. The prosthesis is inferiorly displaced, and there's sagging of the lower lid here. And this patient may be one of those who, when they're talking or doing activities where the prosthesis spontaneously pops out, which can be very embarrassing. So one thing we can do for the lower lid laxity is a fairly simple procedure is lower lid tightening. This is the surgeon's view, and I'm doing a lateral tarsal strip procedure, making a strip from the lower eyelid, and then suturing this strip to the periosteum just inside the orbital rim to bring the eyelid up and make it tighter. And this goes a long way to increasing the tone of the lid, preventing loss of the prosthesis, and also giving a better cosmetic appearance. So for volume deficiency, there's a lot of things we can do. If the patient does not have an implant, we can place an implant. If the patient has a small implant, we can remove that implant and place a larger implant. If the patient has an adequate sized implant in place already, then we have to look for different ways to increase the volume. This is one way I use. This is a subperiosteal wedge. It's a wedge of porous polyethylene that we slide underneath the periosteum or the orbital floor to lift the patient's own implant up and out. This can be made out of porous polyethylene. It can be made out of silicone. There's just different materials. You can actually stack porous polyethylene plates to make your own implant. But this plant is thicker posteriorly than it is anteriorly, so it does lift the orbit implant up and pushes it out slightly. So this is just a quick before after. This is a patient with volume deficiency. You can see a deep superior sulcus. Patient has lower eyelid laxity. Patient has downward displacement of his prosthesis. So this patient underwent a subperiosteal wedge underneath the periosteum to lift everything up. And then I did a lower lid tightening, the lateral tarsal strip. And you can see how that changes the shape of the eyelid. The eyelid has this downward slant, and it kind of sags down here laterally, and it brings that eyelid up and gives that normal almond shape configuration of the lid to recreate the normal anatomy and actually allow the patient to comfortably wear their prosthesis without the worry of the prosthesis coming out spontaneously. Socket discharge is a very common problem we see in patients. When patients come in with their anophthalmic socket, they may say their chief complaint is just like discharge or tearing and so forth. That's very common. It can be caused by inflammations, including giant papillary conjunctivitis. Pyogenic granulomas can occur in the socket. Dry sockets can cause discharge. And then, of course, we have to think of infections. Infections can be bacterial, and sometimes an atypical mycobacteria can cause an infection. Sometimes socket discharge is caused by a poorly fitting prosthesis or a scratched prosthesis that has protein deposits on the prosthesis. If that's the case, we need to remove the prosthesis, clean it thoroughly. If possible, if we have an ocularist, have them polish the prosthesis or sometimes fit the patient with a new prosthesis, because that's a very common cause of chronic socket discharge. So this is a patient, a younger patient with giant papillary conjunctivitis. And this is a autoimmune type inflammation of the tarsal conjunctiva. And it can be caused by protein deposits on the prosthesis. It can be caused by, improper prosthesis hygiene. And sometimes young patients have a very robust immune response. They just get this. If I see giant papillary conjunctivitis, I'll clean the prosthesis, have the prosthesis polished by the ocularist, and then usually I treat them with some type of steroid. I can treat them with an antibiotic steroid combination, such as neomycin, polymyxin, dexamethasone, or with Predforte drops, and that usually will cause this to improve. If you suspect infection, of course, always take a culture, and then if it comes back positive, treat with antibiotics. But most of these cases look pretty characteristic with this lumpy, bumpy appearance of the tarsal conjunctiva, and they can be treated with steroids. Patients that have a lot of discharge in their socket, they come in with a copious amount of mucousy discharge, sometimes can have pyogenic granulomas. And this patient, you can see he has these inflammatory nodules, and you can see this kind of white mucousy pus over these inflammatory nodules. These are pyogenics. They can occur due to minor trauma to the conjunctiva. They can occur if the conjunctiva has not been closed properly during the enucleation, and you have overlapping of conjunctiva over itself and so forth, can cause these inflammatory bumps to occur. These can also be treated with topical steroids, Predforte, antibiotic steroid ointment, or sometimes if they're large enough and they don't respond completely to topical steroids, I will take them to the minor procedure room with local anesthesia and excise and cauterize them. They're very vascular. So this is another patient, came in with socket discharge. And you can see when I've taken his prosthesis out and everted his lower eyelid, he has these two pyogenic granulomas with copious discharge. So these, again, they're very responsive to steroids, but sometimes you do need to actually excise them to make them resolve completely. I don't use motility pegs anymore. I don't know if any of you do, but we used to use these motility pegs, drilling a hole into the implant to place a motility peg pretty commonly. And the patients got great motility, wonderful motility. They were very happy. But almost all these patients eventually develop complications, and the complications include pyogenic granulomas, loosening of the peg, infections, and some patients have had to have their peg completely removed, actually most of them, and some have developed infections within the implant, which required explantation of the implant. Several different studies have shown the same thing. This is one study showing the complications with motility pegs. This was back in 2007. And I think most of us in oculoplastics have kind of stopped using motility pegs just for that reason. This is a patient, one of my older patients that had a motility peg, and you can see just demonstrating the socket movement. He has a flat peg placed in here just for demonstration. You can see when he looks up, he has full motility. This patient had wonderful, wonderful motility for many years, but finally I had to remove the peg because of chronic inflammation and pyogenic granulomas. Now, manipulation of the prosthesis. This is something I always talk to my patients about. I try to not have them manipulate their own prosthesis. I try to have them just come in to see the ocularist and the ophthalmologist every 6 months. And then we remove the prosthesis, we clean it, we polish it, we examine it. And then between visits, I say just don't remove it. If you need to clean it, when you take a shower, just let the warm water run on it in the shower. Try not to remove it. Studies have shown that patients who remove their prosthesis develop more complications as far as infections, inflammations, and socket contracture. So it's better, if possible, to just have them not remove the peg. Atypical mycobacteria is a socket infection that I've seen quite often. These patients develop redness, discharge, infectious signs. I culture them. The cultures oftentimes come back negative, but with time, the cultures may grow this atypical mycobacteria. It's an organism that's ubiquitous. It's found in tap water. It's often difficult to treat. So when I see a patient, I suspect this. I take cultures, sensitivity, and then they need long-term antibiotics, at least 4 to 6 weeks. I use clarithromycin, which in the U.S. is called Biaxin, orally, if the bacteria is sensitive, and I treat them for several weeks, and I add amikacin drops if possible. These infections can be quite severe. This is a patient that had a motility peg, and also she developed atypical mycobacteria. You can see just the destruction of the conjunctiva due to this very aggressive infection. So this patient was treated. We finally had to remove her implant completely, and then we had to, in the future, put a new implant in and do a complete socket reconstruction. So management of exposures, it's quite, a challenge sometimes. So sometimes they'll spontaneously close. If they have a small area of exposure of the implant, I'll have the ocularist try to just make the implant so it does not cover the exposure, kind of vault it over the exposure, and that can work pretty well. Sometimes surgery, if it's a small, we could remove the avascular portion of the implant and undermine and close the Henon's capsule and conjunctiva. Another method I've used is taking tissue from the upper eyelid using a modified Hughes procedure, which I use for lower eyelid reconstruction, and place the Hughes flap on the implant because it has its own vascularity, and you have a higher chance of success in closing that. But sometimes we get exposures like this. This is a patient who came into me from out of the country, and this patient had an implant placed and also had a motility peg, you can see right here, and they had complete exposure in the implant. And this is a porous implant, so it's completely colonized with bacteria. So in this type of case, my technique is to explant the exposed implant, irrigate with antibiotics after I take cultures, just close Tenon's and conjunctiva, wait 3 months. Once I make sure the infection is completely clear, come back and put in a secondary implant. Sometimes after you put the secondary implant in, the socket is very tight, it's very contracted. So what I will do, I will wait another 3 months and then do fornix reconstruction. So I do a stage technique. And I find using that stage technique, I get the best results getting this patient back to a normal situation. So this is just a kind of a recap of that technique. I culture the socket, treat with both systemic and topical antibiotics, explant the implant, primary closure, and then continue the oral and topical antibiotics till the infection is completely clear, and then a secondary implant after about 3 months. And this this recaps this again. The socket is contracted. I do full thickness mucous membrane grafting with fornix deepening sutures, which is in the second half of my talk, 3 months after the secondary implant is placed. Now, secondary implants are a little different than primary implants. I also use a secondary wrapped implant, and you can wrap, whatever implant you have. You can acrylic or silicone or porous polyethylene, whatever you have, just wrap it with something. You could use micro mesh, you could use temporalis fascia, so forth. And then what I'll do, I'll make 3 lines. So I just draw 3 lines on the implant corresponding to medial, lateral, and inferior rectus muscles. I will place this implant in the orbit, and they'll pass 5 ovicral sutures through what would be the insertion of the medial rectus, what would be the insertion of the lateral rectus, and what would be the insertion of the inferior rectus. And I bring these sutures out to the fornices and tie them, because oftentimes in these contracted sockets, the muscles, the extraocular muscles, are scarred into the fornices. And this way, I'm actually tagging the muscles, bringing them through the conjunctiva and tying them. This has 2 benefits. It keeps the implant centrally placed while everything's healing, and it imparts some motility to the socket. And so I've had very good results. This just shows the implant placed centrally and the sutures brought out through the fornices. Then this is closed in this routine fashion, Tenon's capsule and conjunctiva. And these sutures are tied. And I find this works very well. This is a technique that Richard Collin from Moorfields described many years ago. So let's go into the socket reconstruction part of this talk now. So what happens with sockets that are contracted is there's scarring of the conjunctiva in the fornices. The fornices shorten, and the ocularis has to make the prosthesis smaller and smaller, and then finally the patient can't wear a prosthesis, and they can't close over the prosthesis, and they don't look good because they can't wet the prosthesis. So this, I just use the technique. This is using the technique of mucous membrane grafting. This is a patient with severe Stevens-Johnson syndrome that has extensive corneal scarring, fornicil shortening, and so forth. I'm working with the cornea doctors, so I dissect into the fornices, down to the orbital rim inferiorly, down to the orbital rim superiorly, and then I use mucous membrane grafting from the mouth, and I'm going to recreate these fornices using mucous membrane grafting. So I actually harvest mucous membrane graft from inside the lip, and I use this to reconstruct the inferior and superior fornices. So the patient will have fornices be able to close their eye. That's the inferior, superior, and then place a symblepharon ring. And then later on, the cornea doctors can do work on the cornea. They can do a keratoprosthesis or whatever they need to do to optimize vision. So this is just kind of a technique we use in anterior segment reconstruction, but we're going to use this in anophthalmic sockets too, as I'm going to get into. So what are the things that cause socket contracture? Sometimes it's initial conjunctival scarring due to trauma cases. A patient may lose their eye from a trauma, and they may have conjunctival scarring, which can cause contracture. Patients that have suffered burns or chemical injuries oftentimes have socket contracture. Patients with recurrent socket inflammations and infections will, with time, develop socket contracture. That's why it is so important to see these patients every 6 months. They have infections, inflammations, treat them promptly so they don't get contracture. Poor socket hygiene. The patients don't see their ocularist or ophthalmologist. They let their prosthesis get scratched and dirty, and this can cause inflammation and socket contracture. Of course, autoimmune disorders like ocular cicatricial pemphigoid and Stevens-Johnson syndrome can also result in socket contracture. So there's a lot of causes for this, and it's a fairly common thing we see in the anophthalmic socket. Now, socket contracture has different stages: mild, moderate, and severe. Mild, they may have mild entropion, inability to completely blink, and with the inability to blink, loss of the luster of the shine of the prosthesis due to poor wetting. They could have moderate contracture. We have the shortening of the fornices. The ocularist, again, has to make a smaller eye to fit. They get loss of the inferior fornix. The prosthesis may pop out easily, which can be embarrassing. They can have severe contracture where they have complete loss of the fornices, horizontal shortening of the socket as well, and prosthesis where is not even possible. So this is a patient with mild contracture. You can see this patient has an anophthalmic socket on the left. Actually, she looks pretty good at primary position, but you can see the prosthesis has kind of lost its shine a little bit because she cannot close her lid over the prosthesis. So this can cause discomfort, dryness, discharge, loss of the luster of the prosthesis, and a kind of a poor cosmetic result. This is a moderate case. This patient has pretty severe socket contracture, especially inferiorly, where he has shortening of the inferior fornix, and you can see the prosthesis is just almost ready to slide out. He can barely maintain the prosthesis, and in different situations, that prosthesis is going to just spontaneously come out. And you can see he cannot close over it. It's kind of dry with deposits on the surface. This is severe contraction. One can see that the inferior and superior fornices are basically don't exist. And now the socket is also contracting horizontally. So this fissure from the medial canthus to lateral canthus has also shortened. And they have also scarring within the lateral aspect of the socket, causing very, contracted socket and complete inability to wear prosthesis. Another patient, same thing. Basically, your upper eyelid is stuck to the socket here, lower eyelid stuck to the socket here. She has a little bit of mucous membrane here, but completely unable to wear a prosthesis. So this is severe contracture, which we don't want to see. Another patient that I treated with very severe contracture, no socket basically. So what are the steps? This is something, there's a lot of variation depending on the surgeon doing the case, but all of us pretty much agree on releasing the scar tissue all the way in the inferior fornix down to the inferior orbital rim, and in the superior fornix all the way to the superior rim. So I use Westcott scissors and forceps, and when I get deeper into the socket, I use my Stevens scissors and bring them down and touch the orbital rim and spread, and just release any scar tissue. And so I can put my finger in the socket and sweep it around and feel the inferior superior rim. So you've created quite a big space. Then I'll put a large conformer in. Once the conformer fits, then I say I've done my job releasing the scar tissue. Now I have to put in some type of replacement to fill that defect that the mucous membrane used to, fill. So there's different types of implants you can use. You can use mucous membrane from inside the mouth. That's kind of the gold standard. That's my first thing I usually go to because it's patient's own tissue. It fits very well. It's easy to harvest and it doesn't contract much. One can use amniotic membrane. We're going to talk a little bit about amniotic membrane later on. Hard palate graft can be used from the roof of the mouth. One of my colleagues has used that with some success. Dermis fat graft, can also be used from the patient's own tissue. Place in a dermis fat graft, which will replace volume as well as fornices. I always use fornix deepening sutures with bolsters when I recreate a fornix. I'll go over that. Then I put a temporary or permanent tarsorrhaphy after. And then I try to work with an ocularist and use pressure conformers while things are healing to maintain my success that I've achieved from the socket reconstruction. So this is actually the patient's lip. I've everted lip inside out. This is her upper lip. This is her lower lip. I've injected with 2% lidocaine with epinephrine. And I'm taking a pretty big graft. I go to the wet-dry junction here and just in front of the frenulum here, and I make a nice long implant like this. And I dissect just a mucous membrane graft. I take a scalpel blade, I make an incision all around here, and then I just like I'm doing a blepharoplasty, I just dissect a nice thin mucous membrane graft. I clean the graft off. I make sure I clean the submucosal tissue off. I soak it in an antibiotic solution for a while because you are removing tissue from the mouth and putting it in the socket. So it's by definition dirty tissue. So I soak it. And then this is kind of one technique that I like to do. This is that whole mucous membrane graft you saw. The short limb of the graft, I go from horizontally because this mucous membrane graft can actually reach from medial to lateral. And then I need all this tissue because I'm going to tuck that all the way down into the inferior fornix and then come back up. So I'm going to suture this medially and laterally and then along this line. And then I take a muscle hook and I push this down to the inferior fornix. And then I'll bring it back up. I'll measure the amount I need, trim it, and then suture that in place. And then I'm going to put fornix deepening sutures here, which I'm going to demonstrate in just a minute. And then I have frost sutures for a tarsorrhaphy. So let me go over these techniques a little bit more. This is patient severe socket contracture, as you can see, releasing all the scar tissue inferiorly, superiorly, placing mucous membrane grafts all the way down to the inferior fornix and back and all the way up. And then I take a small band. I place double arm sutures through the band, and I'm going to bring those through the inferior orbital rim and out through the skin. So this is another patient that illustrates. This patient was in the Middle East, and he was unfortunately in a Jeep that hit an improvised explosive device in Yemen, and he lost one eye, and then so that's the one we're reconstructing the socket, and he had a lot of damage to the other eye. So you can see I'm taking a big mucous membrane graft for this gentleman, and this is a graft going down into the, I've released all the scar tissue going medial, lateral, the short limb going from medial to lateral, because I need all this graft. I take my muscle hook, I'm going to push this down to the inferior orbital rim. Since I released all that scar tissue, I take this muscle hook and I push it down, and then where it comes back up, I kind of mark here. And that's usually about half of my graft, and I'm going to use that for the inferior. Then I'm going to use the other half for the superior fornix. And then I take, what I do is you can take a lot of different materials, but I take this little nerve retractor. It's not something we usually use in ophthalmology, but I cut a little piece of it. You can use a little piece of Foley catheter, things like that. I've used so many different things, a retinal, band. And then I'm going to place double arm sutures through this, 2 of them. And what I like to do is use 5/0 Vicryl, and I place a double arm 5/0 Vicryl through medial and through lateral. And then I try to take a free needle and make this pass, because I'm going to pass these sutures through the implant, through the mucous membrane graft, try to scrape the periosteum, and then come out through the skin at about the level of the inferior orbital rim. And so sometimes when, your graft is a little thin, you could actually sew two sides together, 2 grafts together, as in this patient. So, and then I tie those over the bolsters over the skin, and I leave the bolsters in place for several weeks, and then I just take those out in the clinic. So amniotic membrane, I've had some questions about using amniotic membrane. I have not really used it a lot in these anophthalmic sockets because I find it's thinner, and at least in my hands, it's not as successful. It's very easy to get. You can take it right out of the package, and place it in. And I know some of my colleagues use it. I think this new amniotic membrane, this cryopreserved umbilical amniotic membrane that's recently been on the market, it's 10 times thicker than the normal amniotic membrane we're used to using. And early reports in socket contracture by one of my colleagues, Christy Nelson in Michigan, showed, a moderate success rate, about 50%. So still, I think in my hands, I would use mucous membrane because I think my success rate is higher than that. But it's something, if the patient does not want to have a mucous membrane graft harvested from their mouth, which is a little bit of a, pain for the patient because they have a very sore mouth for about a week, you can use this. And it's, I'm sure it's probably not widely available throughout the world. I know some of my colleagues have used it for other techniques here at Bascom Palmer, but it is a type of mucous membrane, or I'm sorry, a type of amniotic membrane that's a little thicker and it may increase the success rate of doing these socket contracture surgeries. Dermis fat grafts can also be used. I know those are used, especially in patients who've had retinoblastoma, have socket contracture, especially if they've had radiation and so forth. We can harvest the mucous membrane from the lower abdominal quadrant or the buttocks. They do have some downsides. They've been reported to have shrinkage. I've had one patient I used where it grew too much and they had to debulk it and so forth. So it's a little less predictable. One of my former fellows, Dr. Kat Choi and Dr. David C., reported on using a composite dermis fat graft with a hard palate graft in socket reconstruction, and they obtained a good result. So this just illustrates there's so many different ways to do these things. I'm trying to, illustrate one, my technique that I find is most successful in my hands, and other techniques that other surgeons are using. So when you take this dermis fat graft, you can either take it from the left side of the abdomen like this. You try not to take it from the right because you don't want to leave a scar there, because then if a patient comes in with abdominal pain, to the ER, patients, surgeons may think they've had an appendectomy in the past and so forth. So we do it on the opposite quadrant or the buttocks as well. And this is just a dermis fat graft I've taken out. You can see when you harvest it, you want to go straight down to get a nice thick dermis fat graft. This is the dermis, and that's the fat. You can see it's a very robust area of fat, and that can be sutured into place. And I know a lot of my colleagues swear by dermis fat grafts, so it is another technique you could use. I find it's unpredictable as far as either shrinkage or growth, especially in kids. It can actually grow as a child grows. And I had one kid that had to have several debulkings of the dermis fat graft to achieve a good result. So then, to prevent recontraction of the socket post-op and conformer loss, it's very important to post-op care of these patients. Again, I try to put in these fornix steepening sutures with bolsters, because I find that helps a lot. I usually do a temporary tarsorrhaphy with frost sutures. I place, 4L silk frost sutures through the upper and lower lids, tie them together. You can even create a permanent tarsorrhaphy and then separate it later on in these really contracted sockets. So this is a patient that I place these fornix steepening sutures. This is just an inferior fornix reconstruction. I just tie these bolsters over a little cotton from a cotton tip applicator and leave those in for a couple of weeks. You don't want to tie these too tight because they can cause indentations of the skin. And then this is another patient with these fornix steepening sutures, his conformer in place, and these bolsters in place on his lids. And you can see I can just clip these sutures, pull out the sutures, take these bolsters off, and then take the prosthesis out and gently remove the bolster that I placed in, either the nerve retractor or a retinal band from the inferior fornix, and it's pretty easy. Now, if you have a good ocularist that can make a pressure conformer, that would be ideal. I know that's not available in a lot of places. I'm lucky I work with a really talented ocularist here, and he made this pressure conformer, and it has this stem on it, and the stem I can he puts a little device that has a flat disc here that can apply pressure to the socket, especially when the patient's sleeping at night. So you can see this is a pressure conformer, and the stem with the flat disc can be placed in that little opening there and apply pressure when the patient's sleeping at night, which works really well. So anti-metabolites, this is something I use quite often in really, especially patients that have recurrent contracture, patients have had treatment before and so forth. You can use 5-FU mitomycin C. I like to use 5-fluorouracil. I give some at the time of surgery. I may give 10 milligrams per mil, and may give just inject 1 cc in the area. And then when the patient comes back about 2 weeks after surgery, I may inject a little bit more, a little bit more 5-FU. And I may do that 3 times during the post-op period to help prevent socket recontraction. Other surgeons have used mitomycin, I think it's fine. 5FU, at least in my institute, is readily available, and I find it works really well. So again, the two ones that are most widely used to decrease this fibroblastic activity, or 5FU, and then there are different protocols using 5FU and phytomycin. I like to use 10 milligrams. I usually put the first one in at the time of surgery, and then 2 weeks after, maybe 3 weeks after, and then 4 weeks after, depending on the amount of scarring and so forth. So I'm going to leave a little time here for questions, answers. I do have a couple of questions, cyber questions that I'm going to quiz you all on. Let me do that, and then we'll have like about 15 minutes for questions and answers. This is Miami Beach. You ever get a chance to visit us in Miami? We have beautiful beaches, and that's sunrise on the beach. So what percent of patients with motility pegs experience complications? 12.5%, 91%, 67.4%, or 0.3%. Okay, here's the answer, okay? Yeah, so most of you got that right. It's 67.4%. Correct. Good job. So everybody's paying attention. So, okay. The anophthalmic socket syndrome is characterized by 1, volume deficiency, 2, downward prosthesis displacement, 3, lower eyelid laxity, or 4, all of the above. Okay, we're just waiting for the votes to come. Oh, wow, you guys did great. 90% got the correct answer. That's excellent. Okay, and then one more question here. Which of the following is not a cause of socket contracture? So this is a negative, which is not. Chronic infection, regular prosthesis polishing, recurrent inflammations like giant papillary conjunctivitis, or history of trauma. Which of the following 4 is not a cause of socket contraction? All right, you did very well. The answer is regular prosthesis polishing. That actually can help prevent socket contracture by keeping a healthy socket, keeping a nice smooth prosthesis that the patient blinks over, preventing infections and inflammation. So regular prosthesis polishing is something that will help prevent socket contraction, where the others all can contribute to socket contraction. What do you use for soaking the mucous membrane graft? I use a gentamicin solution. You can use any antibiotic solution, but I like to use gentamicin solution for that. What do you mean by heat curing? By heat curing, it's the prosthesis is made of an acrylic, and the acrylic has to be set. It has to be cured, and the ocularist has different ways they can do that. If they do it with cold curing, it doesn't actually set the acrylic as well. Heat curing actually kind of cooks the prosthesis overnight for maybe 24 hours, and the acrylic has a lot less impurities and so forth. And I find that prostheses that are heat cured have less complications. That's something the ocularist does in the fabrication of the prosthesis. Okay, so let me go up here. So, when using the mucous membrane graft, you cut the lower part in the lower lid from the upper lid while suturing that of the upper lid. What I do with the mucous membrane graft, I actually make separate incisions for the inferior and the superior. So they're 2 separate incisions. And, I make it, several millimeters away from the lid margin. I don't want to get too close to the lid margin, but usually I make it 2. So I'll have 4 suture sites, 2 for the lower, 2 for the upper. One, more toward the implant, and the other more toward the lid. So it's 2 separate sites. Let's see. Let me go up. Okay. 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 How to use dry amniotic membrane? Which is better, wet or dry? Is there any difference? I don't think there's probably any difference. The dry amniotic membrane has to be kind of reconstituted, so you have to wet it first, I think, to make it more easier to work with. But I'm not really aware of any difference between using the wet or dry. Can I cover the acrylic implant with amniotic membrane for better outcomes? You could. I think if you're covering the acrylic implant with amniotic membrane, if you could get the thicker one, I think that might be a little more robust because you could actually suture the muscles into the thicker one. But I think that's a possibility. There's a lot of things you could cover it. You can get a commercial Vicryl mesh over it, so with suture supplies, and you could wrap the implant with that. I find that's a very easy way to do it as well. Can we use medical grade silicone to make ocular prosthesis instead of PMMA, or else is it safe? If it's medical grade silicone, I would think it would be safe. You have to be careful if it's not medical grade silicone that can have, impurities or so forth that would make it not safe. But if it's a medical grade that's used for any type of implant in the body, it should be okay, I would think. How to practice ocularity in your city? Um, we have several ocularists in the city, and they usually do an apprenticeship. They usually work with an ocularist before they develop their own practice, so they are well trained and so forth. The ocularists have a society, the ABO, American Board of Ocularists, and they have different qualifications and so forth. Not every ocularist is a member of that board, but I think that helps to maintain a practice in the city. But there's a couple of different ocularist societies, so if you're interested in ocularity, you can contact those societies. They may list job offerings, apprenticeships and so forth. So for the concentration of gentamicin, what I do is I use a 20 milligram vial, and I put it in a medicine cup that probably has about 10 cc's of saline, and that's how we mix it. It's kind of a dilute. We call it Gara soak. We dilute the gentamicin. It comes in a little vial that's 20 milligrams in saline to make a soak. So it's a dilute concentration. Any advice on anophthalmia in children? Yeah, that's a great question because, anophthalmia in children, I have a whole talk in congenital anophthalmos, and it's, we're trying to achieve several things. We're trying to get the orbit to grow so the patient doesn't have facial asymmetry. We're trying to get the lids to grow. So I find if I have an ocularist that can make small conformers and then just keep gradually enlarging those conformers to help stimulate the socket to grow, and try not to perform any surgery at all on the socket until the patient is 4 to 5. When the ocularist has expanded this completely as good as they can, then I put an implant in and I see if there's any extra ocular muscles. And then I continue working with the ocularist with prosthesis. We actually wrote a whole chapter. I have a book on anophthalmia, the expert's guide to anophthalmia, on Springer, and we have a whole chapter on congenital anophthalmia. It is a very challenging and controversial topic because people have different opinions on things to use. Some people use these hydrogel implants. I don't like them. I think it expands too quickly. Some people do surgery early. I think that's really not good. I try to never disrupt the lateral canthus and so forth. I try to not disrupt the socket because there is kind of a pit in the socket, and if you can stimulate that pit with these gradually bigger conformers, that the socket will grow. And I find that doing this conservative technique of using gradually expanding conformers, working with the ocularist and working hand in hand, and then when the patient is about 5 years old, putting in an implant and continuing with conformer therapy, they do really well. What is your opinion for inflatable implants for anophthalmia in children? I don't really like them. I've seen complications with them. I don't think they work as well. I think they kind of destroy that pit. This is my personal opinion. I've seen more complications from those, so I don't really use those. Let me think. I think I skipped a few questions. Okay, let's see. A lot of questions. Okay. Uh, your opinion concerning making hyperpeg treatment over prosthesis. Do you encourage this? I'm not sure what hyperpeg is. Um, if it's anything with pegging, probably not. How are you washing the socket cavity with saline solution in case of infection? Again, I use that gentamicin solution to irrigate. I just irrigate copiously, and then I may inject a little gentamicin subconjunctively, superiorly, and inferiorly. And I'll take the 20 milligrams, and inject a little bit superiorly and inferiorly for that. So I use gentamicin a lot in these cases. How much the duration can keep the ocular prosthesis without removing, cleaning, and disinfection for the eyelids? That's a great question because I know a lot of patients don't have access. I would try, if you can, to bring the patient in every 6 months, even if the prosthesis is not polished, at least to clean it. What I do is I take the prosthesis out, I kind of scrub it clean with water. I soak it in hydrogen peroxide for 10 minutes. I rinse it off with saline really well, and then I put it back in the socket. And I find if I could get at least clean it every 6 months, I prefer to clean and polish it, but at least clean it every 6 months. It's going to help a lot. In children, if we do enucleation with the implant, the eye is going, how do we handle as orbit size is increasing? Great question. I try to put as large of an implant in a child as I can, and even in young kids, I've been able to put in an 18 pretty easily in most cases. And then sometimes I do have to change the implant later on to a larger implant. But again, I'm also working with the ocularist to with the conformers to help expand the prosthesis. Okay. I had a let's see, socket reconstruction mucosa from lip. After 2 weeks, it started to contract again. Yeah. Instead of anti-metabolite, I injected steroids. Do I need to wait, or how long do I need to wait for another socket reconstruction, but using a cheek wrap? Good question. Yeah, steroids will help if you don't have the anti-metabolite. Steroids will help. I would wait probably at least 3 months before doing another one because you still have that fibroblastic activity going on. Try to work with an ocularist if you can, to to keep a nice conformer in there to keep everything on stretch. What is his opinion on inflatable implants? I don't really like them. I know some people use them, some people swear by them, but I think they inflate too fast, and I don't think they give you good long-term result. What is the best retention system for these trademark? Best retention. I'm not sure what epithesis. Yeah, I'm not really clear on the epithesis. Hang on a second. Okay. Um, can we put a prosthesis on microphthalmic eye directly for cosmetic? Yeah, you can. If that I have several patients like that who have microphthalmic eyes. I just leave the microphthalmic eye in for their implant, and then if they don't have corneal sensitivity, then I could put a prosthesis right over it. If they have corneal sensitivity, you can actually do a conjunctival flap over the cornea, like a Gunderson flap, something like that. You can scrape the epithelium off the cornea, advance the conjunctiva over it, and then, decrease the sensation. And you could use, keep the microphthalmic eye in place. You don't use, yeah, you can use povidone iodine to clean the socket. That works very well too. Sometimes they use a combination of povidone iodine with hydrogen peroxide, and I think that works as well too. So let's see. How much do you work with oncology patients? I work quite a bit with oncology patients. I see a lot of patients with pediatric orbital tumors, adult orbital tumors, lymphomas. I have a lot of skin cancers, sorry, such as basal cell carcinoma, squamous cell carcinoma, sebaceous cell carcinoma. Merkel cell carcinoma. I work with oncologists because some of these patients have metastatic disease with orbital tumors and so forth. So we work with the oncologists quite often. Do you give lubricants or artificial tears for dry anophthalmic sockets? Yes, that's a great question. I should have mentioned that. One of my ocularists has a really good technique where he has the patient buy mineral oil at the pharmacy without a prescription and just use a drop of mineral oil on the prosthesis every day. It keeps it more moist. Do you clean the prosthesis before 6 months if infected? If it's infected, yes. If it's infected, I'll clean it. I'll make sure it's clean. I'll treat with antibiotics, but I don't take the prosthesis out. I'll clean it. I'll put the prosthesis back in, because if you take the prosthesis out during an active infection, you're likely to get contracture. So the prosthesis will help prevent it from contracting. So leave the prosthesis in, and then clean it real well, treat with topical and maybe systemic antibiotics for the infection. How can I avoid contracting socket after evisceration? That's a great question. I mean, evisceration is a great technique. You should, once you finish your surgery, the socket should look just like a enucleated socket. Shouldn't really look any different. I would just do all the things that we talked about, make sure the patient, if they have inflammations, infections, come in and have them treated right away. Have them clean their prosthesis, polish their prosthesis every 6 months, have them avoid touching the prosthesis, and so forth. Can we do dermis fat graft socket reconstruction in pediatric congenital anophthalmic socket? I don't like to do that because I think that's going to disrupt the socket architecture. I would rather expand it with these conformers first, and then put in just regular prosthesis. I think, in the long run, they'll have a better result. If you don't have that available, then of course, dermis fat graft is another technique, but it's not my preferred. Will it help the prosthesis to become more clean if we keep in betadine? No, I don't try to keep it in betadine. I would rather just clean it every 6 months in my office and then have the patient not touch the prosthesis. So yeah, I try not to do that. Let me see. Did I answer? Let's see. I think I got everything. If I didn't get your question, I'm sorry. I try to get all the questions here. I'm glad you guys had so many good questions, because you went over some of the things that are very important, and it's a challenging topic. But I just want to kind of end up with saying that one thing that is so important that I think the anophthalmic socket has not been a very popular topic in oculoplastic surgery, because it's not one of these glamorous topics like cosmetics, so forth. But these patients are some of my most grateful patients, because if you can kind of give them a really good cosmetic appearance, good comfort, they feel so much better. It increases their self-esteem. It increases their chance of getting jobs, maybe finding their life partner, things like that. It really changes their lives. And so those are some of my most grateful patients. So I think if you really treat these patients well, you maintain them in your practice, you see them every 6 months, it makes a huge difference in their lives, and they're going to be some of your most grateful patients. So preventing complications after surgery, we kind of talked about that, using the pressure conformer, maybe using 5FU if they have contracture, using the temporary tarsorrhaphy. Thanks for sharing knowledge. You're welcome. Thank you. Can we use a propylene mesh instead of micro mesh? Yeah, I think you can use that. All right. It's been a pleasure talking to you all, and I look forward to my next webinar with you all. So please give me any feedback, input on this talk. And if you have any questions in the future, you can always email me through the Bascom Palmer Eye Institute website. Thank you very much.